week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
Our first presentation is Jordan Spurling, coming to us from Grady Memorial Health, presenting on the incidence of precipitated withdrawal during a multi-site emergency department-initiated buprenorphine clinical trial in the era of fentanyl.
My name is Jordan Spurling. I'm originally from Chicago. I did my pharmacy school at the University of Kentucky and my PGY1 at the University of Illinois, Chicago. So I've got our little fan club up there. And now I'm a PGY2 in emergency medicine at Grady. Today, the journal that I chose is entitled Incidence of Precipitated Withdrawal during a Multi-Site Emergency Department-Initiated Buprenorphine Clinical Trial in the Era of Fentanyl. And here are some of the things that I'll be going over today. So let's talk first kind of about the waves of the opioid epidemic. So when we kind of talk about the opioid epidemic from an epidemiology standpoint, we kind of characterize it in three distinct waves. So the first wave kind of begins with increase of prescribing of opioids in the 1990s. Overdose deaths involving prescription opioids, both natural and semi-synthetic, including methadone, increased since at least the early 1990s. And that's kind of the predominant drug of that time for overdoses. And then kind of moving into 2010, that's when that second wave begins to emerge with rapid increase in overdose deaths involving heroin. And then in 2013, the kind of third wave begins with significant increase in overdose deaths involving synthetic opioids. So in particular, involving illicitly manufactured fentanyl. And so while that market is kind of ever evolving, what we can see now is a lot of combinations of heroin, counterfeit pills, and cocaine being mixed with this fentanyl. So the CDC came out with a statistic that between 1999 and 2020, more than over 500,000 people have died from overdoses. So definitely a problem that we're still seeing and is very common in our emergency departments. So here are kind of some of the treatments that we use for opioid use disorder treatments. We see methadone and Suboxone are kind of the predominant ones, where naltrexone can be used inpatient, but it's more for alcohol use disorder. And we know that these medications work. So this is a trial that came out entitled Comparative Effectiveness of Different Treatment Pathways for Opioid Use Disorder. So this was a retrospective comparative effectiveness research study that assessed de-identified claims from Optum Labs data warehouse. So these looked at patients that were insured, they were over 16 and had opioid use disorder. Looked at over 40,000 patients that were insured. So again, that might potentially skew it because these patients did have insurance and kind of access to care, but looked at it between 2015 and 2017 with both Suboxone and methadone. And as you can see, at 3 months, there was a 76% reduction in overdoses with these patients that had access to medications versus not having access to medications. And at 12 months, it still had a 59% reduction in overdoses. So this is just one of the many trials out there that kind of supports the use for medication-assisted recovery. So if we have these medications that show that we can help all of these patients, then why are all patients getting it? Well, there are significant gaps in care, unfortunately. So if we look in this orange bubble, we see that 41.1 million people were in need of treatment for substance use disorder, and less than 10% of patients actually received any treatment whatsoever. Going into this dark green bubble, we see that 2.5 million Americans in 2020 were diagnosed with opioid use disorder, where only 11.2% of those patients actually received any medication treatment. So moving into the light green bubble, we see that there are fewer than 2,000 programs providing methadone. And when we think about what that really means in the United States, thinking about some of those more rural areas where care is already harder to come by, and just thinking about how much more of a barrier that creates for these patients. And then moving into yellow, only 11% of opioid use disorder programs actually provide medications. We know that these are things that can really help our patients. So, that's kind of a shocking number to me. And so due to these restrictions and barriers to prescribing Suboxone, access to this highly effective and safe treatment is severely below what is needed. And so a lot of people are trying to brainstorm, well, how can we kind of close those gaps? And a lot of these trials are coming out with initiating medications in the emergency department because that has a very low barrier. Patients don't necessarily need insurance. They don't need appointments. They don't need a lot of access. They can kind of just come right to the ED and potentially get care. However, that might be something that is also viewed as a barrier for emergency department staff, as all of our numbers are increasing kind of across the country. All of the emergency department visits are increasing. And so we're kind of taking on this role as a primary care or urgent care, where sometimes we don't have the resources to really provide care to these patients. So again, just something to consider with even more barriers kind of coming up for these patients. But moving into Suboxone, so this is a medication that we're going to be focusing on today and seeing if it might be feasible to initiate in the emergency department. So we know it's a partial mu agonist with that really high binding affinity and a small amount of activation. It's used as a harm reduction agent and kind of this maintenance for opioid use disorder. One of the major adverse drug reactions that I'd want to point out, however, is this precipitated withdrawal. And that's something that a lot of patients and providers are equally concerned about. So that would be something that we're going to talk a little bit more about today. But that does happen because it has that high binding affinity and can kind of kick off the opioids on the receptor. However, it doesn't have the activation. So it kind of drops a patient from a high level to a lower level very quickly. Here are some of the strategies of Suboxone initiation in the emergency department. We see macro, traditional, and micro, traditional, and macro. So micro is these much lower doses, and that has a really low risk of withdrawal because they are kind of those lower doses. However, it can take a very long time for a patient to become therapeutic on this. So, not maybe very feasible for an emergency department initiation. Looking at our traditional, starting with 2 to 4 milligrams daily, having a COWS assessment and kind of increasing that as we go, you can potentially achieve therapeutic levels at this dosing. However, again, not very feasible for the emergency department. So our kind of standard of care is this macro dosing. So giving them 8 to 16 milligrams daily. However, the perception is that this will precipitate withdrawal. And you might be thinking, well, what is the big deal about precipitated withdrawal? Like, yes, it probably doesn't feel great. However, this is something that is very traumatizing to patients. If you speak to a patient that's ever had to go through any withdrawal, it is something that they take very seriously, that they are truly terrified of. So we just need to make sure that we are really taking all the necessary steps to make sure that we're not precipitating this in any manner. So looking at some of the data kind of surrounding emergency department initiation of Suboxone, this was a trial looking at initiating this in an emergency department. And it basically compared 3 different interventions. So it looked at referral, looked at brief intervention, which is basically talking to the patient, seeing what their goals are and referring them accordingly, or looking at actually initiating Suboxone in the emergency department. So this trial looked at over 300 patients between 2009 and 2013. And 78% of the patients in the Suboxone group versus 37 and 45 referral and brief intervention were engaged in addiction treatment at the 30th day of randomization. So showing that they had a much higher follow-up rate if they were given treatment with a medication. Also looking at buprenorphine group reduced the number of days of illicit opioid use per week. So previously they were at 5.4 days per week, moving down to 0.9 days per week. And that was all self-reported. So kind of the conclusion of this trial was that emergency department initiated Suboxone versus kind of this brief intervention or significantly increased engagement in the addiction treatment, and also reduced that self-reported illicit opioid use, and also decreased the use of inpatient addiction treatments. So also making sure that we're utilizing our resources appropriately. Then there was this other trial that came out in 2020, and this was a systematic review that looked at all of the different dosing strategies for opioid use disorder and pain management. So they looked at kind of 2 separate groups, a group that was microdosed Suboxone and a group that was traditionally dosed. And of the group that completed microdosing, about 40% of patients still experienced some sort of withdrawal symptoms as assessed by the authors. And then patients that were regularly dosed, 60% of patients reported experiencing some withdrawal. So some of the things about this is we're not really sure when their last use was of their opioids. So that's something about this review that might potentially lead to some gray area with this. But their conclusion was that clinicians should individualize Suboxone initiation for each patient. So it might not be great for every single patient to be given or initiated Suboxone. So now we can go on to our trial. And our trial, just one more time, is Incidence of Precipitated Withdrawal during a multi-state emergency department initiated Suboxone or buprenorphine clinical trial in the era of fentanyl. So this study looked at, the objectives were to provide evidence from a prospective study using uniform surveillance and operational definitions of precipitated withdrawal. So kind of these pre-specified definitions. Also, it wanted to detail the incidence of precipitated withdrawal as part of an ongoing clinical trial, and then to compare both traditional sublingual buprenorphine with an extended release injectable. So the way that the study was designed, like I said, it's part of an ongoing clinical trial. So it looked at 1,200 patients enrolled over the course of June 30th, 2020 to October 26, 2022. It looked at 28 geographically diverse emergency departments. And of those patients, they would be assigned to either a sublingual buprenorphine or this extended release. This right here is just the study drug name. And depending on their COW score in the sublingual group, if they had a COW score greater than 8, they would be started on 8 milligrams and discharged with a prescription of 16 milligrams per day. If they had a lower COW score, they would have an ED induction of up to 12 milligrams and again discharged with a 16 mg per day. If they were assigned to the extended release Suboxone group, they would get the 24 milligram injection. And the reason they did that is because those doses would be equivalent to the sublingual group. Definition of precipitated withdrawal was predefined and has a COW score of greater than or equal to 5, or if they required any additional buprenorphine or ancillary medications. And then if there was any suspected precipitated withdrawal, they were documented, and it was documented prospectively, and it was adjudicated by expert consultants on the back end. And something that I noticed while I was looking at other literature is this is a very low threshold definition for precipitated withdrawal. So definitely hoping to capture more people with this definition of precipitated withdrawal. So some of our inclusion and exclusion, they had to be adult patients with moderate to severe opioid use. They had to be opioid positive, determined by a urine drug screen. And they also had to have a COW score of 4 or greater. Some of the exclusion was pregnancy, and something I did think was interesting is methadone positive patients were excluded from this. So we can talk about that a little bit later. But the outcomes that this was looking at was we were looking at the reported incidence of precipitated withdrawal, both in the sublingual buprenorphine group and in the extended release injection. And then secondarily, we were reporting on the demographics of these patients that are experiencing precipitated withdrawal. So kind of looking at our baseline demographics, we have 1,200 patients total. Just over half were men, or I guess 66% were men. The age or average age was in their 30s. See that the predominant race identified as white, followed by African American. And then looking at their housing, they were asked if they had unstable housing. So in the past 12 months, over 50% stated that they were experiencing unstable housing. Currently, it was about 37%. And then looking at kind of their substance use characteristics, so we see that the most common route was nasal route of use, followed then by injection. And then also looking at our severity of use. So of the past 7 days, how many days of those was spent using or have you used? And that was at 5.31 was the average. And then looking at the urine point of care testing, so we see here that there's like an opioids category, then there's kind of fentanyl down here, and then some other miscellaneous drugs. Something that I did notice is that the opioids were actually consistent of either fentanyl, buprenorphine, oxycodone, or any other opioids, but that was excluding methadone. So the most common was having some sort of combination. So multiple different kind of opioids or an opioid plus one of these other drugs that were screened for. We also have like a high prevalence of fentanyl, fentanyl with no other opioid, fentanyl in addition to another opioid, fentanyl with other drugs. So kind of what this would tell me, I guess, is that patients may not always know what they are taking, especially in the illicit form. So that is just something to kind of consider when we're talking to our patients, is that we're kind of looking at a mixed picture. Also looking down here, we see that a lot of patients, 16.5% also had benzos in their system. So kind of these high risk patients, or kind of adding to the risk of these patients. So without further ado, kind of our primary outcome. So of the 1,200 patients enrolled, only 9 experienced precipitated withdrawal. To me, that is a pretty small number to kind of reach that endpoint. And then because we did have such a small number, trying to assess their baseline characteristics is a little bit trickier. There's nothing here that I really want to point out that really stands out to me as far as a baseline characteristic of these patients that experience precipitated withdrawal, except for the fact that there was this sublingual and extended release, that they look pretty even. Again, it's really hard to tell since there's really a small sample size. Something that I think is a little bit more interesting is, again, their substance use history. So if you look at these patients and their severity of use, kind of in this dark blue, we see that of the last 7 days in their use, 7 of them used 7 days per week, and then 2 of them used 6 days per week. And so the average in this trial was 5. So these are definitely a little bit higher patients that may have more severe use profile. And then as far as route, it all looks pretty even. And then moving into our urine drug screen, we see that all of them have fentanyl. Of course, the opioids include fentanyl as well, but kind of looking at this mixed picture, not really too much to say except that these patients did all have fentanyl in their system. And that is definitely kind of reflective of the current drug climate. So looking at kind of what the author concluded, the author said that Suboxone induction in the emergency department is both safe and effective, and that access to Suboxone is essential in combating the opioid epidemic. As for kind of my assessment of the study, there were definitely a lot of strengths. So it was a geographically diverse emergency departments. There were 28 of them included. So I think this really does a good job of encompassing the drug supply in different populations. So kind of assessing what's happening really all over in the United States. Also looking at our trial, they did have a very high prevalence of fentanyl, definitely reflective of the current drug supply, and having a lot of patients with kind of mixed use picture is definitely like what we're going to be seeing in real life and real practice. Also, there was a very large population. So 1,200 patients were enrolled in the trial, which I think is quite a lot. And then more strengths of the study, there was very high patient follow-up. So 86% of patients followed up at day 7. And as we saw in some of those previous trials, the numbers were about 70% for patients that were getting medication for their use disorder, and then like 30% when patients were not given any medication. So this is definitely a lot higher than some of the other trials that I've seen. Again, kind of nodding to the fact that medication can be very, very effective in these patients. Also, they did have that low threshold for withdrawal, so a COWS score of greater than equal to 5, or any of those ancillary medications hopefully will catch more patients that potentially were experiencing withdrawal. And then also this was a pilot trial, so this really is the first prospective trial that adjudicated outcomes of Suboxone and precipitated withdrawal incidents. So some of the limitations that I noticed about this study is kind of this contribution to precipitated withdrawal. So the urine drug screen was not very comprehensive. So potentially there is the potential for these undetected fentanyl analogs or nitazene to maybe have contributed to precipitated withdrawal. There was also patients that may have been missed to follow up. So 14% of patients didn't follow up. And was that potentially due to having precipitated withdrawal? We can't be sure. Also, this drug formulation is not currently available. So I guess we will see with that upcoming study that will come out if this may be a formulation that would work for us, and if that might be something that we could implement into practice. Also, there was no comment during the study on return to use. And I think that this is something that is very tricky because you do have to incorporate what is the patient's goal. Do they just want to be like safer? Do they want to quit completely? Do they want to meet somewhere in the middle? So just kind of making sure that we, assess what the patient wants and kind of meeting their goal, and making sure to kind of define that in the trial. So my conclusions, again, I would have liked to see kind of what the return to use was. And I guess the better word would be like, is the patient meeting their goal? And I didn't see any comment on that. So that would be something that I would like to see. Also looking at the dosing of Suboxone. So in this trial, the patients were sent home with 16 milligrams per day. And if we're using the macro dosing protocol, like while that is what we would initiate in the ED, those can go up to much higher. You could send a patient home on 24 mgs per day. So we could potentially not be treating these patients appropriately. If patients have more severe use, are we really covering them as much as we should? Also looking at the characteristics of precipitated withdrawal, there were some characteristics. Some of the things that I think I would want to point out is that the patients did have higher use per week than patients that did not experience precipitated withdrawal. So that might be something that we'd want to consider. And then they excluded methadone positive patients. So we know that the pharmacokinetics of methadone is erratic and increases the risk of withdrawal. So I guess we couldn't really apply this study to patients that may present methadone positive. And do we have the resources to kind of implement a drug screening to know if the patient is methadone positive? I feel like in most emergency departments, we might not have access to that comprehensive drug screen. Also, the follow-up definition, they did say that there was follow-up at 7 days, but that wasn't really specified what that follow-up looked like. So some of the things that I would think about when trying to initiate this in an emergency department is having that protocolization, having that barrier that we need to have a multidisciplinary team to potentially put a protocol together and kind of figure out all the nitty-gritty of how to incorporate that into our workflow. Also looking at patient perception and provider perception. So if a provider has previously used Suboxone and precipitated withdrawal, is that really something that you're going to be able to convince them to try again? And same kind of with the patient. If they've ever experienced that kind of precipitated withdrawal, it might be very difficult. So kind of promoting that open conversation, and we might not have the time to really go into depth with that. Also looking at these urine drug screens, what is that going to cost for an emergency department to implement? What kind of time does that look like? Just a lot of other barriers. And then how do we get that into our ED workflow? So these are some of the barriers that I would think about if I were to start incorporating this into my practice. And it does have to be very, very patient specific. So with that, I will open it up to questions, and thank you all for coming.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.